Just because we're talking about the myodura bridges and it's like a new potential, biomarker here, I want to make sure everyone understands it very, very well. So you're suggesting that they might stiffen in Chiari patients. So as far as like your theory on how that translates to symptoms, is it that the bridges are blocking CSF flow? Can you explain that a little bit?
Yeah, I think so. So two things. Good question. I like that. Also, yeah, they are part of also because like how Dr. Svokos said earlier, that sometimes we have like a Chiari zero situation, where we don't see much. Certainly, we don't believe the 5 millimeter anymore. We are on the same page on that. But of course, but can we get more mechanistic evidence? And it looks like, it might be the milder ridges, that just make the dura stiff, so the dura cannot regulate the spinal fluid flow anymore, so maybe could it be like that, the dural non-compliance, the stiffness of the dura that doesn't move anymore, so it doesn't help the spinal fluid circulation of the base of the skull. Could that be also a Chiari zero problem? So that's what we're saying, and how does it relate to symptoms? Well, kind of the Chiari-like symptoms. But it could also be, and that's what Dr. Sullivan said. She said that the base of the skull and the structures have a lot of nerves there, right? Like all the innervations. The myodural bridges are also innervated. They also have all these tiny nerves in the myodural bridges. So certainly could, if they become stiffer and inflamed, could it be that they also trigger some of the pain, So basically, and that's also been like traditionally thought that milder bridges are pain triggers. And there was a surgeon like 30 years ago that actually took milder bridges out in patients after whiplash surgery because he felt that was a pain trigger. Unfortunately, he did it too early because back then that was so controversial. He got himself into trouble for doing this, But he did the patient a favor, but he did not himself a favor. But now we are 30 years later, and there is a little bit more of a, like belief in that.
Mm-hmm. Um, you kind of bridged this, so I'm going to go Dr. Focus next. You showed a really great picture of the cranial nerves, like in surgery. So I know we get a lot of questions from patients about some kind of weirder symptoms that they or their children are experiencing. So I guess the question is, can the cranial nerves be irritated in the context of Chiari, and are there any symptoms that you've seen associated with that kind of squishing, for lack of a better word?
Yeah, absolutely. You in the picture of the brainstem from the atlas show that they're all coming off the brainstem, and that's being pushed by the Chiari. So, depending on the compression, you typically it's the lower cranial nerves, which are 7 and below, 7, 8, 9, 10. Most commonly 9 through 12. So we can see any of these, but most commonly is the lower cranial nerve. So 10, 11, 12, because they cause trouble with, those are the choking and the swallowing nerves. And sometimes they can have trouble with their vocal cords, so trouble breathing, and those are more of the 9 and 10. So, and then you saw my kid having cranial nerve 6, so it can even go that high. So it just depends. But we've seen a big variety, broad range
Mhm.
of dysfunction.
Absolutely. Dr. Sullivan, you talked about, differentiating migraine, tension, headache, and nerve pain. So, how do you differentiate that in the clinic, I guess is the first question with the patients that you're talking to. And then you also mentioned some medications that were maybe helpful. So can you kind of talk through some of those as well?
Yeah, so generally I ask patients about their migraine history. Unfortunately, I think I also have migraines, so I think part of being a good clinician, I think, is bringing in your personal experience. So I tend to ask some very migraine-minded questions. What have you tried triptans? What are your triggers? When do the headaches sort of come on? I think that reproducibility with pushing. So occipital neuralgias or pains that are reproducible to kind of physical manipulation tend to be more related to kind of the neuropathies. So that tends to be something patients will sometimes try to self-treat in a collar, and a lot of the collars too will rub up against that posterior occipital sort of nerve. And so those are the types of things I usually ask, just sort of practical questions. A lot of the injectable kind of migraine prevention medications I think are really helpful. So depending on if the patient's in like a resource limited area or in an area where there's neurologists who are more kind of up to date on some of the different treatment options, I think a lot of patients will have been, trialed on sumatriptan or Imitrex or other types of triptan medications, which again, never worked for me. So I think, talking to patients about behavior modifications triggers, physical pressure points, and then looking at anything that could be externally applied, things like a collar, all those are reversible. And then I think tension headaches do tend to respond better to PT, especially if it's a PT specialist who understands connective tissue disorder. So really kind of getting deeper into that. And if there's any associated, if it's a migraine with aura, that's much less likely to be attributable to something from a neuropathy.
Cool. There was a question that came in before we even met today that is a not logical next step here. Are there any natural therapies, exercises, or devices that any of you recommend to maybe prevent even needing surgery in the first place?
I don't know if you guys have any thoughts from a cervical spine pain perspective. In terms of like natural therapies, I think depending on if the patient has a tethered cord, the application of traction is very helpful for patients who have purely degenerative pathology. It's really unhelpful for patients who have a tethered pathology. So I will typically tell patients, like, if you've already tried it, what was your response? But otherwise, I try to avoid it. Any patient who has hypermobility, I encourage them to avoid things like a chiropractor, anything with manipulation. Massage acupuncture, I think some patients find relief. There's a new device that's coming out from one of the companies that we work with that's giving constant stimulation to promote new ligamentous, new kind of soft tissue healing for microinjury. They use it a lot in athletes. So that's something that's kind of coming out that's a non-invasive option. And then from a physical therapy perspective, kind of chin tucking, that chin tuck maneuver sort of open up and stretch the posterior ligaments, and then posture correction. So anything we can do to kind of improve what I'm doing poorly now, which is rotating back the shoulders and just grabbing onto the wall and pulling yourself forward, can help that lower subaxial spine pain.
Dr. Klinge,
Yeah.
Dr.
Yeah, so certainly, like Dr. Sullivan gave a very comprehensive overview. Of course, when we think of the myelor bridges, as we know, and that's physical therapists with manual therapy, or they call it also cranioocervical therapy, can, manipulate the ligaments. And could it be, if we think that those ligaments are stiffened or inflamed, could we work on relaxing them, and could that improve the dural compliance, So I think what if we have more data on the study that we're doing right now, really showing that it is a dural compliance issue, we probably should reach out to physical therapists and kind of tell them also, hey, look, what you guys, do has a correlate, and it's not just like speculating that we're working on the ligaments. It's like really a evidence. So I think that would be important, but we still need to get a little bit more data on that, what we're doing, obviously.
Do you want to add anything, Dr. Svokos, or?
I think the Dr. Sullivan and Dr. Klinge covered a lot of this, and for me, I was a osteopath, which means that my medical school was osteopathic medicine. We also did osteopathic manipulative treatment, so non-invasive manual treatment of the cranioocervical axis. So these are done by family physicians who are DOs, and some of them incorporate them in the practice. So the patients are they can seek out doctors who offer these in their practice, and it's covered by insurance, and it really works. I no longer use it. I trained in it in school, but it really helps in a non-invasive way.
Awesome. Want to make sure I'm doing the right. So you already kind of talked about this, but you use traction sometimes to ensure the neck. Oh, this is actually a surgical question. So when you're doing a fusion for CCI, for example, do you use traction to ensure the neck is in the best position prior to fusing, I assume?
When we apply cervical traction, the easiest way to apply cervical traction is when a patient is supine. So if a patient's laying on the bed, then that is typically the upward forces of traction are going to force the head kind of back into a more neutral position. But it's more effective on the lower kind of subaxial spine. So it's more effective at creating lordotic or kind of normal spine curvature. In patients with suspected CCI or any type of ligamentous instability, we have to be really conservative about how much force is applied, specifically because we don't want to induce something like an AOD. So so yes and no. If we're operating on the back of the neck, we usually have the patient in a device called a Mayfield that holds their head really tight and stable. So what we do is we get x-rays before doing any of the instrumentation so that we know that the alignment looks good. And specifically there, more than just the position of the neck, I'm looking to make sure that the angle of the mandible, kind of the back of the jaw, is not like this. Because this type of a position, it makes it really easy to operate. And that's actually how we do the Chiari positioning, is sort of with that flexion. But no one can eat and swallow this way. So we're a little bit more concerned, I think, with proper opening of that retropharyngeal space. So we want to make sure that the space posterior to the mandible is open. So that's a bigger concern. And then again, if a patient really has signs of ligamentous instability, I would not apply traction because it's going to create problems.
I want to get through some like symptomology questions, like diagnosis. So there are a couple of questions about tethered cord, whether or not it can be developed later in life or you're born with it and it just becomes a problem later. I don't know if Dr. Klinge wants to speak to that or anyone else. Oh, you're muted still.
So yeah, sure. We as I said, like Dr. Svokos, Dr. Sullivan, and I, we treat a lot of adults with tethered cord, and we certainly understand, like what we call the adult onset tethered cord syndrome. So the answer basically is yes, there's a lot of adult onset tethered cord going on. Why is that? Well, it could also be like the same mechanism that we see with the myodule bridges, like our phylum, that's tethering our spinal cord is also a ligament, right? And if we live our life, we certainly just naturally pull on it all the time. So we mechanically overuse that phylum as well. And as I shown in that graph, mechanical overuse can make a ligament stiffer. So the concept that we're trying to sell now is adult onset tethered cord syndrome basically also due to stiffening of the phylum. Some of our biomechanic data has already shown that, but we're looking more into that. I think, yes, that is aging and stiffening of that ligament is causing adult onset. I don't know whether Dr. Sullivan or Dr. Svokos want to say some adding to this.
I think with the adult onset population, the hardest thing I think for me, and this is where I kind of get involved most in the practice, is when there's degen as well. So when there's disc herniations, when there's other sort of obvious pathologies that could be contributory but don't really explain why the patient is as symptomatic as they are. And so that's where I think the older age group could sort of, you just have to kind of add more to the workup. So looking a little bit more closely at with back pain, it's much more likely you're going to see joint or facet disease arthropathy, and other things that might be, normal, a normal degenerative kind of progressive stuff, just the effect of gravity versus something more serious.
Dr. Svokos? Pass. Okay.
Unmuting myself. No, I have nothing else to add.
Okay. I'm gonna just send this to everyone. So does the diagnostic criteria for Chiari change if a patient has a large syrinx versus something maybe a little less visually concerning. So either a small syrinx or what someone might call like a dilated central canal, which really borders on normal. Um, do the diagnostic criteria for Chiari in either of those cases change, or are they the same? Does one concern you more than the other, surgically speaking? Oh.
Yeah, I can start. Um, I mean, certainly, like Dr. Svokos has shown, like the variation of the syrinx. Of course, like traditionally, like a larger syrinx worries us more, because the reason is like we know like th there is not a lot of real estate in the spinal cord. And if the syrinx is large, we have to assume that there is pressure or stress and strain on the neurons. And as you know, classically, like we tell, look, um, uh, when we have a patient with the syrinx, it's not so much that the diagnostic criteria change, I would say. It's more like that we have to tell the person, even if we decompress your Chiari and even if the syrinx is getting smaller, the symptoms associated with the syrinx, like like arm pain, arm dysesthesias, temperature dysregulation, like spinal cord symptoms, they might not get better as much because there's also like changes, structural changes that might not change. So I think the only thing is what I like to say in my experience. Um, the patient with a very large syrinx, they often do not have as much headaches. So I believe that's just what I experience. They have, of course, more the syrinx problems, but if I tell them, hey, do you also have pain in your head when you cough and sneeze? No, not so much. So it must be that already, the spinal cord has taken the heat. So all the pressure dynamics are in the spinal cord, and you don't get that cranial pressure impression as much. But that's not a good sign. So basically, in a patient with a syrinx, I would not walk away from the patient because they don't have that typical Valsalva headache. They probably have it all in their syrinx.
Anyone want to add anything? Okay. um, a couple of surgical, like pre-surgery questions. So someone had sent in a question about having had whiplash a few times. I know we kind of talked about this a little bit. Previous neurosurgeon had told this person that they needed plates and screws in their neck, or they would be kind of basically in the danger zone of, losing ability to walk, paralysis, stuff like that. So they're asking, is there any way to strengthen those muscles to hold everything in place enough? I know we talked a little bit about PT, and I know you talked about, Dr. Sullivan, some bodily mechanisms that are really meant to stabilize that joint. Is there anything that can be done to ensure that that happens, I guess?
Yeah, it's a good question. I think with and it's the most frustrating answer, I'm sure, for this person because the answer is it depends. So I think your body's natural ability to compensate for some of these problems really depends on your own kind of comorbidities and other issues. Smokers are much more less likely to kind of have successful fusion with like conservative measures and more likely to have complications when we do fusions. Um, I've really expanded my practice too to include a lot more endocrinology. So making sure that there's no thyroid dysfunction, B12 deficiency, vitamin D or calcium deficiency, maintaining it's very boring, I think, for patients, but like maintaining a protein-rich diet, making sure that if there is any sign of osteoporosis or osteopenia, getting started on medications to sort of benefit that. For patients, depending on the age of this patient, for Medicare patients, it's a lot tougher because they either have to meet an age category or have a severity on the DEXA scan. So all these things, it depends on what your resource level is, what your ability is to kind of access those options, and your own kind of native comorbidities. I would say that for anybody who's confronting a fusion, especially something as serious as a cranioocervical or occipitocervical fixation, get a second opinion. If there really is a risk of neurologic decline, your safest bet is to have a fusion. It's very difficult to guarantee that someone is going to be safe without it. And I think our biggest fear is that very small, low risk things like a fall in somebody who has a spine that's like quote unquote normal or that is functioning with less hypermobility. Um, if that hypermobility progresses to instability, like in a whiplash injury where there's ligamentous injury, and you have another low mechanism fall or another accident or another whiplash, there's less security. So we think about kind of longevity, but always get a second opinion if you're not sure. And that's kind of the best way. Once you hear it from multiple opinions, sometimes people can make a little bit more peace, or there might be other surgeons out there who have other suggestions for conservative.
Anyone add? Question in the chat about cranial cervical instability, something called pseudofusion. Just says, what are the options? Any suggestions? Any ideas or about that?
I'm assuming that would be like a non-instrumented fusion, which would be, a pseudo fusion. This is really against semantics.
Yeah.
Arthrodesis is when we lay down bone graft material. So the goal of a fusion is the instrumentation is holding things in the proper alignment, and then you arthrodese or add bone graft, and that's what encourages the body to form new bone. In a pseudo fusion or a non-instrumented fusion, I'm assuming it would be grafting without instrumentation. I think with a collar and in the right patient population, especially kids or younger folks, I wouldn't have any issue with it, especially if it was a first try. I think just anytime you reoperate through a space that's already had surgery, it makes it harder if the patient requires a revision. So any type of a off the beaten path surgical approach, just remember that if I do a lot of revisions for outside hospital surgeries, and it makes my job a lot harder. We have navigation now, but when I go in for a CCI or a C12 approach, in my mind, I'm thinking about where the vertebral artery should be. And if someone's already been in that space and there's bone where bone shouldn't be, it makes it a lot harder for me to go to safely fuse without navigation, because then you've lost all your anatomic landmarks. So, oh, instrument fusion skull to C4. Pseudo fusion. If you're doing instrumentation with an arthrodesis, I don't know why they're calling it pseudo fusion, unless a patient had a prior fusion and it didn't work. We call it pseudoarthrosis. Yeah. So if there's a pseudoarthrosis, that means the instrumentation didn't take. Usually that's a patient factor. We see that a lot in patients with connective tissue disorders, just because the hypermobility translates to a lot of stress on the screws. It's a tricky problem to fix. We here use bone stimulators for patients, and like I said, the bone adjuncts. So for someone who's had a pseudoarthrosis, we would recommend endocrine workup, optimizing kind of their intrinsic bone status. We can use bone morphogenic protein, although it's kind of off-label in the cervical spine, and then a bone stimulator externally with a prolonged period in a brace. I hope that answers the question.
The best you could, yeah. Dr. Svokos, you typically talk, I'll get to that for sure. Do you typically talk with your patients about which graft material you use in surgery? I know you talked a little bit about, allergies and stuff like that. Is that something that patients should be asking about when they talk to their surgeon? Is it something typically discussed at all, or?
Yes, they should be talking to the surgeon about it. And to give you a perspective, in fellowship in Colorado, all we used was a pericranium graft. So we were harvesting it from an incision that was small and away from the Chiari incision. So I trained with that. And then when I got here, I was using that. And then because of Dr. Klinge, I changed my practice. So I started using the ALLODERM. I haven't seen a difference in a CSF leak or healing from it, but some things to consider is that a lot of our patients have allergies. So now in these patients, I do discuss it, the ALLODERM, and how it's a foreign material. And some it's bovine. So some patients for religious reasons don't allow that. So, and some patients are vegans and they don't want any animal products given to their kids. So in those cases, I do change the practice, and it's a great question that we should talk about it in this post-surgical planning.
There are like 4 questions I want to get to, so bear with me. I'm sorry. I do want to start with Dr. Klinge. You showed that slide with improvements in cognitive function. I want to talk a little bit about this. It looked like attention improved the most. Do you have a theory about why that might be specifically?
Yeah, so that's also something that uh, uh, um, like Phil Allen has shown with some of this work that um, there is like mm, uh, so the limbic system is like the core of our memory processing, and meaning like where you store and also get your information out. And there are connections, bidirectional connections between the lower portion of the cerebellum, close to the tonsils, and the limbic cortex. And so so if you help this connection, you process everything faster. So, and that of course, gives you a better attention span. And that's how you have, like you can uh, uh, focus on things better. Uh, that's basically like a connectivity thing. It is really more, I mean, look, if you I'm not a computer scientist, okay, but our cerebellum really is a can be seen as a backup computer, and a backup computer needs a lot of like space, and in order to make the computer go faster, if our backup computer has less space, uh, you wait a long time to download like a PDF file or something, so if we decompress our cerebellum, our backup computer, and make more space, our computer goes faster. So that, I think, that applies to attention.
Perfect. I'm going to ask a quick question. Dr. Sullivan, you had mentioned something about skin erosion towards the end of your talk. Is there any way to prevent something like that?
It's hard because it's the back of the head, and so it's right where you lay when you're sleeping. So adequate nutrition, for a lot of our connective tissue patients, wound healing is a pretty common problem. So trying to place the plate, like the occipital plate, lower, kind of where it's not in a dependent region. But the angle of that occiput is sort of different in everybody. So, and we're limited by the position of a really large sinus called the torcula. So we kind of have a limited window, and it's their own anatomy that sort of factors into where the plate can sit. And then intraoperatively, it's kind of where it fits with the remainder of the surgical hardware, because we have to line it up with the lower cervical level. So we're a little bit constrained, and sometimes it's hard to predict. Sleeping on a good pillow, maintaining good nutrition status, and then being mindful. There's not a lot of tissue mobility on the skull. So in terms of like plastic surgery closure, complex things like that, there's really not a lot of options. And then just making sure that you use the lowest profile plate that you can.
There's a really good question that came in the chat, so I'm going to ask that one other one, and then I'm going to do a quick request that people help us plan the next 10 years of our organization. But first, it said that apneas are a common co-occurrence. I know we talked about like the cranial nerves, stuff like that. But are you aware of any correlation with these conditions and brainstem pathway impairment resulting in like REM sleep behavior disorder without atonia? It's very specific. Anyone at all?
Is it possible to just briefly, so we are asking about like REM sleep and
REM
how that is.
sleep. I guess the co-occurrence of REM sleep disorder, apnea, and I'm assuming Chiari, although I don't know if they're also talking about CCI or any kind of instability issue.
Well, to the REM sleep, I can say something. Certainly, like again, same thing, cerebellum connected, to like, I think there is like, it might be, so I'm not a neuropsychologist, okay, but in the post-central gyrus, there are also connections, there is like a control center that is involved in sleep regulation, so the thought is that also, like it's more like even a cerebellar issue and not a pressure issue, like a really structural cerebellum issue. For example, the same thing with so in Chiari, one other symptom is like, for example, cerebellar seizures. These are like episodes where you just kind of freeze, with everything, and you have like a seizure-like impression presentation, and it's not really like a seizure. So these kind of, like cortical, like you know, like global alterations can be due to cerebellar issues. I'm not sure about cranioocervical instability in that. I don't think that there's any knowledge about it. I don't know whether Dr. Sullivan has other thoughts.
A little harder for me to comment on just because unfortunately, like a lot of my patients with degenerative pathologies, we see yeah, obviously apnea is multifactorial. So if weight's a factor, I mean that's obviously a hard one to modify. And then there's, you know, craniofacial things and ENT type things too that I just don't think I have a good grasp on it. I will say I have to go, so I apologize. There was just a clinical phone call. Is there any other question for me? I'm trying to reply to the
Well, you did a great job, which
yeah.
was really helpful because then I can just ask my final question, which is really about research. And if you have to go, that's totally fine.
But thank you so much, and sorry to hop off.
No worries. No problem.
Okay, thank you.
So the last question really is just what other research is being done on CSF flow, shunt complications, and essentially like how do you identify when a patient's case is too complicated for surgery, I guess, when there's like better options other than going into the OR, which I know those are two separate questions, but I don't know if you can address either.
You want me to address this? Well, I mean, the thing is, I would say, of course, I would say things become complex and not too complicated, okay? Because we always try, you know, to find our way through and give answers. I would say complex means like when we understand that multiple comorbidities, you know, like play in. For example, where pain has become a very huge chronic component where we know that the pain might have already centralized. You know, we know about that phenomenon that you learn pain. And often these are individuals, you know, that have a high pain level also on a day-by-day basis and a long history of pain. So if pain becomes a really main contributor to the quality of life, then of course that is concerning because we know with whatever we do, we cannot fix pain. And of course, if whatever you have, like shunt plus Chiari, plus tethered cord, plus Syringomyelia, if already like multiple interventions have been done, there is certainly also like a limit to a surgery, you know. So you have to be mindful of like not offering another surgery because the tissue becomes inflamed. And for example, our brain layers, the arachnoid, becomes more scarred and you really cause an inflammatory process and no longer like a solvable situation. So I would say if you see you know, like that there is like more pain and inflammation involved in the picture, then I think surgery is limited. What are the alternatives? Well, you know, of course, there's a lot of research done in anti-inflammatory disease. I mean, shockwave therapy, you know, like micro frequency therapies to break up inflammation and scars, and physical therapy, physical measures, and of course, medication is out there to help neuroinflammation. But I think the neuroinflammation, and that's also the next step of research, neuroinflammation is a big element that we have to look at how inflammation in our nervous system is maybe triggered by surgeries or triggered by viral diseases or triggered by just the disease itself. You know, like in every of our chronic neurological conditions, neuroinflammation is a part. So that's where the research has to be looking at, also for Chiari, to understand, you know, like the implications.
Dr. Svokos, do you want to add anything before we wrap up?
No, nothing to add. That was good, Dr. Klinge.
Okay, thank you.
Oh,
Thank you.
there's another question that just popped in. Does releasing the tether cord help improve CCI or reduce the need for fusion? Releasing the tether cord can help the CCI symptoms. Sometimes, well, most of the time, if there's no CCI, no instability that needs fusion, it does make some of those neck pain, instability symptoms, the tension in the neck better because you release the spinal cord, so everything is more under less tension. Does it prevent CCI fusion? Not necessarily, right, Dr. Klinge? They may need the fusion down the road, and I educate patients that we see before CCI surgery and before tethered cord surgery that the usual order of surgeries is tethered cord release first, followed by CCI surgery, because the CCI adds traction, and it can make the tethered cord symptoms even worse if that surgery happens first. So that's the order that we usually recommend.
Yeah, I mean, that's here, Dr. Svokos and I are pediatric neurosurgeons, right? And there, the concept of releasing, the bottom of the, spinal cord might help, the dynamics. And, there's publications out there where tethered cord release had helped, like alleviated Chiari symptoms and also the impression of Chiari. So that's why we recommend that order. Yes. But certainly, it's always a very individual decision making. Everyone is unique, as we know.
Awesome. Thank you both so much. This was excellent. We heard a lot about basically the vanguard of where this research is going. One thing I'm going to plug shamelessly a little bit is that Bobby Jones CSF is doing a prioritization of what patients and actually caregivers, if you're Dr. Svokos or Dr. Klinge, you're willing to take a part in it. I'm putting something in the chat right now. What we want to do is make sure that our advocacy, education, research, all of our programs are focused on what matters to you. So if you have what will basically be a grand total of 20 minutes as far as sign up and then completing the surveys, it shouldn't take longer than 10 minutes once you get started. It's just ranking what you think is most important based on some preliminary interviews that were done with patients and caregivers. And then based on that, we're really going to make sure over the next 5 years, what we're funding, what we're doing is really what you need done. So we'd be bringing this back to Dr. Klinge, our C board. So you would be hearing about it when we get the results. But first we have to get enough people to complete the survey. So if you can, at any point, just save that link. I can send it an email after we're done here. And then anyone, if you have issues with signing up, you can feel free to email me directly. That's my email. And then the survey should be right in when you, I won't post it, but when you sign in, you should be able to do it automatically. You have to sign up first, but it's really important because we want to make sure that what we're doing is relevant to you, to providers, everyone. So, but thank you everyone for coming. If you can't access the survey, just email me at that at that email and I'll get in touch. But thanks everyone. Sorry, that was not succinct at all. I appreciate it.
Thanks for having us,
Thank you so much.
Caitlin. Thank you.
Thank you, Dr. Klinge.
Bye-bye.
Bye-bye.